once again the postgraduate training program, the API-ICP's virtual postgraduate training program. This is going to be the last week of PSG Institute of Medical Science, Department of Medicine's presentation. Next week onwards, we are going to have presentation from the Trichy Medical College. And really thank Dr. Tyagarajan, consultant endocrinologist, and Dr. Sendil Kumar, consultant endocrinologist from PSG Institute of Medical Science and Research, for being the faculties for this evening. And really thank you both of you for this evening acceptance. And we have with us Dr. Divya Bharati, the postgraduate from Department of Medicine from PSG Institute of Medical Science and Research, is going to present the topic of endocrine case. And over to Dr. Tyagarajan and Dr. Sendil Kumar to take over further proceedings, and requesting Dr. Divya Bharati to present this case. Thank you.
Thank you.
Sir, good evening, sir. Shall I start?
Yes, please. Yeah.
I'm going to present an endocrine case. A 38-year-old male with no known comorbidities, coming from Coimbatore, working as a computer science engineer by occupation, came with chief complaints of headache for 2 years, palpitations for 2 years, weight loss of 15 kgs in 1 year, blurring of vision for 8 years. Instead of presenting illness, patient was apparently normal 2 years ago. Then he developed headache, which was a left-sided intermittent headache, dull-like, around 2 to 3 episodes per day, lasting for 4 to 5 hours, which was with no aggravating or relieving factors, and was not associated with aura, photo, or phonophobia. A headache was associated with vomiting, which was projectile vomiting during the episode of headache, containing food particles, non-bilious, non-blood-stained. Blurring of vision for the past 8 months, which was painless, initially started on the lateral aspect of both right and left eye, with the loss of vision on the lateral aspect of both eyes, not associated with watering, double vision, flashes of light, or waving button or halos, no history of oscillopia or polyopia, no aggravating or factors. History of palpitations for the past 2 years, which was intermittent, regular palpitations, not associated with chest pain, breathlessness, or syncope, no aggravating or factors, not associated with polyuria or post-palpitation diagnosis. History of unintentional weight loss for 15 kgs in 1 year. No history of seizures, altered sensorium, no history of any trauma or fever, no history of any weakness of limbs, no history of any loss of taste, loss of smell, no history of difficulty in eye movements, no history of sensory loss over pace during disturbances, no history of loss of taste, salivation, angle of deviation of drooling of saliva, no history of hearing loss, vertigo, tinnitus, no history of nasal regurgitation, nasal tongue, dysphagia, hoarseness of voice, no history of dysarthria. No history of heat intolerance or tremors, no history of increased frequency of stools, no history of urination or increased hunger or thirst, no history of galactoria or loss of libido, no history of easy petrichordia, no history of fetal edema or abdominal distension, no history of any bleeding manifestation. Past history, not a known case of type 2 diabetes, systemic hypertension, TB or epilepsy, no history of any surgeries or drug intake. Personal history: consumes mixed diet, has normal bowel and bladder habits, normal sleep pattern, does not smoke or consume alcohol. Family history: no history of similar complaints in the family members. Summary: 38-year-old male, no known comorbidities, presented with complaints of headache, vomiting, and palpitations for the past 2 years, with weight loss of 15 kgs in 1 year, blurring of vision for the past 8 weeks. Shall I proceed? Differential diagnosis includes intracranial space outline lesions, hyperthyroidism, pheochromocytoma, uncontrolled diabetes, chronic TB, meningitis, and shall I proceed, sir?
Yes. So yeah.
Okay. Examination: patient was conscious oriented, age comfortable at rest, moderate. Tremors was present. No pallor, interest, cyanosis, clubbing, demand lymphadenopathy. No features of acromegaly, no features of hyperthyroidism. Secondary sexual characters, no. Thyroid and lower cavity, normal. Height was 173 centimeter, weight 63 kg, BMI was 20.8, and height neck ratio was 7.2, and arm span was 180 centimeter. General on vitals, BP 100/70 millimeter, measured in right arm supine position. 110 millimeter in bilateral volume. Pulse rate was 130 beats per minute, regular rhythm. No specific character, felt equally in all peripheral muscles. No radiofemoral decay. Saturation was 98%. Respiratory rate was 18 per minute, above thoracic, and temperature was 98.2 degrees Fahrenheit. Cranial CNS examination, higher mental functions were normal. Cranial examination, second cranial nerve, visual field showed bitemporal hemianopia. 3/4 cranial nerves were normal, other cranial nerves were normal. Motor system, sensory cerebellum were normal, and no signs of meningeal irritation. Serious examination, palpation, trachea was midline, apical lymph was felt in left intercostal space. The midclavicular vein was hyperdynamic, no parasternal, no palpable sounds. Auscultation, mitral area, first and second heart sound was heard. This one was soft. A high-pitched blowing hollow systolic murmur of grade 3/6 radiating to axilla and back, burst heard with the bell of the stethoscope, with the patient in left lateral position at the height of expiration. Tricuspid area, first and second heart sound were heard and no added sounds. Pulmonary area, first and second heart sound added sounds. Aortic area, first and second heart sound were added sounds. No carotid booty. Respiratory system, bilateral normal vesicular sounds were no added sounds. Abdomen soft, non-tender, no organomegaly. Probable diagnosis cellular mass with suprastellar extension arising from as he had bitemporal hemianopia and headache. The thyroid toxicosis as he had palpitations and weight loss. With moderate mitral regurgitation as he had pansystolic murmur in the mitral area. No vaccine. On investigation, TSH was elevated, P4 and P4 was also elevated, and GH growth hormone was elevated. Other hormones were normal. MRI showed a lobulated cellular mass of 5.5 cross 4.5 cross 6 centimeters. Supracellular and paracellular extension. Echo showed mitral valve prolapse of AML and PML, moderate to severe mitral regurgitation, dilated atrium, mild ER. So he was treated with endoscopic transperineal surgery. It's currently on hydrocortisone 10 mg OD and injection octreotide 30 mg monthly once and tablet 10 mg OD. Repeat MRI showed residual lesion in paracellular region of 2.9 cross 1.8 centimeter. He is planned for radiotherapy and transperineal surgery.
Okay, Dr. Dev, you have finished, is it, Dr. Dev? So,
Yes,
what is your final unifying diagnosis?
probable pituitary cellular mass with supracellular extension. Pituitary adenoma, secreting TSH and growth hormone.
Why growth hormone also?
GH was also elevated.
Okay. So you can call it, is it pituitary macroadenoma, isn't it?
Yes, yes.
Anything more than 1 centimeter is pituitary macroedema. And you told about pansystolic murmur as well. Did you want to include that in your diagnosis?
Yes, sir.
Then what would be the final diagnosis? So pituitary macro. Yeah, tell me. Yeah.
Macroadenoma with mitral regurgitation.
Right. So what are the cardiac? So pituitary macroedema. It's functional, isn't it? So what is it causing? So
Hypersecretion.
hypersecretion of. So it's probably secondary thyrotoxicosis, isn't it? Hmm? Yeah. Are you able to hear me?
Yes, sir.
Yeah. So tell me about what cardiac manifestations you will see in a patient with thyrotoxicosis.
Will be high output cardiac failure. From pulse can be tachycardia, sinus tachycardia, supraventricular tachycardia, atrial fibrillation.
Okay.
Pulse pressure will be wide pulse pressure.
Okay.
There will be signs of high output cardiac failure.
Okay. Yeah. So there will be heart failure. It's called thyrotoxic cardiomyopathy.
Yes.
And sometimes they can develop acute dilated cardiomyopathy also. So you told us about the pansystolic murmur, isn't it, in thyrotoxicosis in this patient? What are the murmurs you will or murmurs or extra sounds you will look out for in a patient with thyrotoxicosis?
Flow murmurs.
Flow murmur. Okay, good. Anything else? Flow murmurs usually you get a ejection systolic murmur. Anything else? Anything over the gland? Anything you will listen?
Bruise.
Thyroid bruit, not carotid bruit. Thyroid bruit. What about heart murmurs? Anything else?
Means Lerman scratch.
Yeah, good. Means Lerman scratch. What is it? Yeah, you're right. Tell me why does means Lerman scratch happens? So it happens because of
Hyperdynamic states.
hyperdynamic pericardium rubbing against the pleura.
Yes.
So it's a mid-systolic sound.
Yes.
It will mimic a mid-systolic click. And then any other murmur you can hear more commonly? Means Lerman, good. Anything else very commonly heard? Can you hear pansystolic murmur like in this patient?
Yes.
Yeah. So why do you get pansystolic murmur in patient with thyrotoxicosis? Is there any association?
Because acromegaly can have mitral valve regurgitation prolapse.
Acromegaly, more of cardiomyopathy it can cause, not mitral valve prolapse. But what is thyrotoxicosis? Can you get any? Is there any association? Because this patient you said the mitral regurgitation and echo showed mitral valve prolapse. Is there any association between mitral valve prolapse and thyrotoxicosis?
Dilated cardiomyopathy. Second.
Yeah, good. That's one of the causes. So basically, there is an association between mitral valve prolapse. It's very common in, not very common, it's relatively common in people with thyrotoxicosis. Okay.
Okay.
So, especially in Graves' disease, because Graves' disease is autoimmune. So it can happen, with autoimmune thing, there can be lymphocytic infiltration and this accumulation of all these proteins, glycosaminoglycans, everything in the leaflet, causing mitral valve prolapse or regurgitation when it gets worsened. Second cause is what you told before, that is dilatation of the heart chamber because of long chronic hyperdynamic circulation, and there will be dilatation of the valve annulus leading to regurgitation. Okay.
Okay.
So this MEP can progress to mitral registration in extreme cases of thyrotoxicosis when they are not treated. So this patient, what did the echo show in this patient? MVP is or MR?
Yes, the moderate to severe
Severe MR. Okay, okay. What are the commonest causes of mitral regurgitation?
rheumatic
Okay.
acute or chronic.
Yeah, you can classify as you like. Yeah.
Ischemic cardiomyopathy. Just mitral valve prolapse.
Yeah.
Rheumatic heart disease, mitral valve prolapse.
Yeah.
Infective endocarditis.
Yeah. There you can get acute, isn't it? Yeah.
Cardiomyopathy.
Okay. Anything else? Yeah. All the connective. Yeah.
Marfan's.
Yeah. All the connective tissue diseases like SLE, Marfan's, Ehlers-Danlos, and all those things. Okay. So likewise, it happens in thyrotoxicosis, especially autoimmune as well. Okay. I think if you go deep, it will be more of cardiac case presentation than endocrine. But just for an exam purpose, I'll ask one question just in this. What are the signs of severe mitral regurgitation clinically?
White pulse pressure.
Yeah, okay.
Hyperdynamic apex with downward shift, outward shifts.
Yeah, when they go into failure, it can happen. Anything else?
Soft S.
Yeah, soft S1, good. Then?
S3, sir.
Presence of S3, okay, then?
Murmur of more than 4 grades.
Yeah, murmur
Relating to
sound. Yeah, that.
axilla and back.
Yeah, okay. What happens to S2?
S2 will be white split, sir, because of
Why?
early A2.
Okay, early closure of A2, it will be widespread. Okay, good. So these are for your exams. Okay. Good. Okay. Okay. So, Dr. Tyagarajan, do you want to ask her anything?
Sir, so for just what's the signs that you would differentiate it from primary hyperthyroidism, like say Graves' disease?
Graves' disease will have ophthalmopathy signs.
Okay.
Gland will be enlarged in secondary.
Gland will be?
Enlarged in secondary.
Sure, yeah. So, it could be, even in Graves also, it could be slightly enlarged, but yeah, so in this Graves presentation, you mentioned that, the thyroid gland was normal. And in this particular case, the clinical symptoms were very, prominent. And then you had a TSH high, the values of very high values like, 54 and free T4 of 18. But sometimes if the TSH value is only mildly elevated or within the normal limits and the T4, T3 are high. So what would be your differential diagnosis in those situations?
Like multinodular goiter.
No, what I'm talking about is T4, T3 are elevated, but TSH is normal or only slightly elevated.
Drug intake.
Okay. So normally when you have hyperthyroidism, right? Like primary hyperthyroidism such as Graves' disease or toxic adenoma or toxic multinodular goiter, in those situations, how would the thyroid function test would be? How would the TFT would be?
Primary hyperthyroid TSH T4 elevated.
Yeah, TSH will be
Decreased or low normals.
No, no, TSH will be definitely very suppressed. Hello?
Yes, sir.
Yeah, can you hear me now?
Yes, sir. Yes, sir.
Yeah, okay. So yeah, in primary hyperthyroidism, the TSH will be very suppressed,
Yes, sir.
below the lower limit of the lab measurable normal
Yes,
range.
sir. Yes, sir.
Okay. So when that is not seen, then see lab errors can also be there sometimes.
Okay, sir.
Okay, assay interference sometimes can show some abnormal values.
Okay.
Okay, and then there's one other entity, but you may not have heard about. There's something called thyroid hormone resistance. Have you heard about that?
Not sure.
Okay, so the thyroid hormone resistance is one of the major differential diagnosis for a elevated TSH and elevated T4T3 hormones. Just wanted you to know. Okay.
Yes, sir.
All right then. Okay. So. So this case, I think you had the lab work that really shows gave you the diagnosis, and then you went for the MRI. So we didn't have to kind of have other things ruled out as such. Sir, I think I think I have that. Those are the questions I have.
Okay. Dr. Devaparthi, I think as Dr. Tyagarajan said, resistant to thyroid hormone resistance is one of the very important differential diagnosis in this patient.
Okay.
So one thing is it's a rare condition, autosomal dominant, but you might come across occasionally with elevated TSH and T4. But differentiating between this and our patient here with secondary thyrotoxicosis or central thyrotoxicosis is patients with resistant to thyroid hormone will not be that symptomatic. They might be euthyroid because basically it's a receptor level resistance, so they compensate and TSH will be a little bit high. Or sometimes they might be slightly thyrotoxic, but not overtly.
Okay, sir.
But as Dr. Tyagarajan said here, because the TSH was so high, it became easy for us to diagnose and go with MRI and all those things. So you told about the treatment. So what is so obviously you would have read about even though it's a rare endocrine condition which you may not see often in general medical practice, you would have read about this. So what is the treatment options for for the TSH secreting pituitary adenoma?
Reducing the size of tumor, but he has sure symptoms, so we can proceed with surgeries.
Yeah, transsphenoidal
Transsphenoidal surgeries.
is the first line. Okay,
Yes.
but most of the time they may not be able to remove the entire thing because there might be cavernous sinus extension or and all those things. So if there is a residual tumor, what else we can do?
Radiotherapy.
Yeah, radiotherapy can be given. And anything else?
Somatostatin receptor analog.
Yeah, okay. Now we have this longer acting somatostatin analog. How do the longer acting somatostatin analog receptors act?
Suppress,
Yeah, suppress.
suppress the release of hormones.
Yeah. suppress the release of TSH levels. Okay, and in practice, you would have probably used this for a different scenario. Can you tell me any of those general medical scenario where you have used somatostatin analogs? Sorry.
Doctoriotides.
Yeah, what do you use? Sorry, I can't hear you properly. Yeah.
GI bleeding, gastrointestinal
Variceal bleeding. Yeah, not
yes,
variceal bleeding, not GI
yes.
bleeding. So esophageal varices you can use. Or side effects of somatostatin analog? If you use for variceal bleeding, it's going to be a short term treatment. It's not going to cause anything. But in our case, they can develop impaired glucose tolerance and gastrointestinal symptoms like abdominal pain, vomiting, and all those things. Okay. Anything else apart from somatostatin analog you can use? You told initially this patient also had increased growth hormone levels. So anything else you can think of?
GH receptor antagonist.
Yeah. Some of these tumors may be co-secreting prolactin and growth hormone. So you can use carborgolin also sometimes. Okay.
Yes.
So those are the things, and I think overall your presentation was good. So this case is unique because it had combined both mitral valve prolapse and mitral regurgitation and very rare form of thyrotoxicosis. Dr. Thiarathan, anything else you want to add at this juncture?
Um, so yeah, so in the meantime, I think for this patient also you can even use antithyroid drugs, and if you are not able to control the cellular lesion, you can definitely consider even thyroidectomy. That should also be a possibility.
Yeah.
For this patient.
Yeah. Thank you, Dr. Thiarathan.
Yes, sir.
One more thing, Dr. Divya Bharati, what I would like to add is I think you probably didn't think about resistance to thyroid hormone. There are a couple of tests which you can do to differentiate that from TSH secreting pituitary adenoma. Just worth knowing. One is called TRH test, thyrotropin releasing hormone or factor, which you inject normally, it will cause a stimulation in TSH levels, whereas with TSH it could be blunted. Then another is T3 suppression test. These things we don't do it really, but in difficult cases where you do not have any answer, then we can do T3. If you inject, whether you can see whether it suppresses the TSH or not, which again will be blunted in a TSH secreting tumor. So these are the additional points. Just I know it's more endocrine, but maybe worth knowing. And read about atrial fibrillation, role of anticoagulation in patients with thyrotoxicosis, and the patients, if they are general, forget about this patient, but in general thyrotoxic patients like Graves' disease, what are the treatment options you will think of? This might be more, I think, useful for you practically.
Metimuscle or carbamazepine.
Yeah, antithyroid drugs. Yeah, and then I'm talking about Graves' disease, not this patient. On the long run, what would you plan?
Radioactive iodine.
Okay, in Graves' disease, what are the things you should be careful when you're giving radioactive iodine?
Ophthalmopathy, so it can increase person.
Okay, anything else? And pregnancy, breastfeeding, and presence of young children at home and all those things you have to take care of. And if they have ophthalmopathy, still you want to give radioiodine, you could do it, of course, under steroid cover, but explaining to the patient there is a small risk of worsening of ophthalmopathy. And when you start somebody on methimazole or carbimazole, what is the most important instruction you'll tell the patient? Because
reactions, allergy.
what are the side effects or allergies you can get? Sorry?
Agranulocytosis.
Yeah, that is not allergy, but of course, that is the most important thing. That is what I was expecting from you. So, how will you explain this to the patient?
They explain that we will have.
If they have,
we will have to repeat CBC.
you can't be repeating CBC all the time, and you won't know when it is coming. You can do one as a baseline, but not every time. What would be much more easier instruction you can tell the patient?
So basically, Dr. Everybody, what kind of symptoms would you ask the patient to look out for that might mean the patient is going for neutropenia, agranulocytosis?
For bleeding manifestation, infection, fevers, leukopenia.
Yes, usually it's the high fever and the sore throat.
Yeah, it's a very important sign. So if someone has, so you tell them if they have sore throat or fever, like Dr. Karadan said, they have to stop antithyroid drugs and check their CBC and get treated for it first.
Okay.
Okay, good, because it's a very practically important point. You'll be starting a lot of patients on these antithyroid drugs. So this is what you should know. I don't think I have any other questions to ask. We've covered most of the stuff. Dr. Aradhan, anything else you want to add?
I think that's most of it, sir. Yeah.
Okay. Do you have any questions, Dr. Divya Bharati?
Surgery should be started for this patient should be testosterone. We will have hypogonadism.
Yeah, you can, because of the pressure effects and all these things. They can, if they, you can start on testosterone replacement. No issues. Yeah. And also cortisol and other things. See, whenever you have a pituitary tumor, when it is hypersecreting one of the components, the other hormonal profiles can get reduced because of the pressure effects and things. So you have to look out for them and treat accordingly the deficiencies. And once they have the surgery or the tumor is removed, there is always a possibility of these things getting corrected. So you have to check from time to time. Yeah. Sorry.
Radiotherapy.
Yeah, radiotherapy you can give, but this patient is going for a redo surgery. Sometimes when you give radiotherapy, the redo surgery might become technically difficult. So he's going for a redo surgery anyway. So he hasn't had radiotherapy yet. Yeah.
So except for a prolactinoma, most patients, the treatment of choice would be surgery.
Okay.
Like any other functional pituitary adenomas, the surgery will be the first option. And if there's a residual tumor and if there's a possibility of redo surgery, then that should be the second option. Then the third option would be radiotherapy.
Okay, good. Dr. Tyson, do we finish it or what happens?
I think we can finish it, sir. Yeah.
Finishes it? Oh,
Yes,
okay.
yes.
Okay, Dr. Saravanan will be talking now, or?
No, I think he said only if he may log in later, but
Okay.
so yeah.
Okay,
Yes.
okay. 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 Thank you, Dr. Tyagarajan, and thank you, Dr. Divya Bharati, for a nice presentation. I mean, it's a very rare case. I hope we had a useful discussion. You can read about this as well as more important, practically, read about management of Graves' disease and other forms of thyrotoxicosis, and also the precautions you take when you start on antithyroid drugs. And of course, about mitral regurgitation in a bit more in depth. It might be useful for your exams. So with that, I'll finish. Anything else you want to say as a concluding thing, Dr. Jayarajan?
Yes, sir. So I think hyperthyroidism in general. Read about it. Evaluation of hyperthyroidism, or you can start with a patient presenting with abnormal thyroid function test. How do you proceed? And then you can go from there. And most times, one I think I see commonly is that in a hyperthyroid patient, except in certain scenarios, an ultrasound of the thyroid is not always needed. And if at all you're planning on imaging, maybe a thyroid uptake scan, if there are no contraindications, that may be more useful for you in making your management decision. So you can consider that. Otherwise, I think it's a good presentation, a very good case, a very rare one that you might not be seeing one like this. It's very rare to see such a case like this. So it's, I think, a good learning case, and I hope you benefited from this case. Yeah, thank you.
Thank you. Thank you, Dr. Jayarajan. So we'll close the meeting. Thank you.
Sure, sir. Thank you, sir. Thank you.
Thank you.
Good night.
Thank you.
Thank you.